I'm Kristen, and I am a project manager for a nonprofit.
And I'm Dr Colson. I'm a family physician. I came to Boise, Idaho for training. I was really drawn not only to the area, but the fact that this training program trained family doctors to provide kind of the full spectrum of care. So not just clinical work, but also inpatient and OB care, and I continue to do those things.
We have made wonderful friends. They're basically family. We don't have any other family here, and we waited until he got through his residency program before we considered starting a family. And so we started and tried for about a year and unsuccessfully, and then sought fertility treatments. We worked with a fertility doctor for about 5 years total. It was a really long journey for us. Did egg retrievals, did IUI, pretty much, we sought every possible opportunity for us to start a family.
We did have conversations early on, if there were certain kind of risks to Kristen or, other kind of health reasons that we wanted abortion to be able to be on the table, but it was kind of one of those things where I think it was like, we'll cross that bridge if and when we come to it, rather than like a daily kind of looming fear that we had.
I was nervous as well. Throughout the process, I have unexplained infertility, so we don't really have any clear answers of treatment that would work for me. And so I was experiencing recurrent pregnancy loss. Total throughout our journey, I had 5 miscarriages. And so, as the laws progressed, there was a lot of questions of like, I don't know if I can carry babies to term. What does that look for me if I get past a certain point? And, we talked about it a lot, and we wanted so badly for it to work. And the laws were kind of adding an extra layer to everything that we were going through already. This particular pregnancy, I went in for a 7-week ultrasound. We learned during that visit on ultrasound that I had what's called an anembryonic pregnancy, which means that the embryo implanted, but it didn't actually grow. Because this was my 5th miscarriage that I was having, I was very familiar with the different options that I had available to me, and had a conversation with my provider about which route I wanted to go, and based on my previous medical history and things that I had experienced with some of the other options, I chose the medication management for this one. So the prescription got sent to my pharmacy, and normally I receive a text letting me know that my prescription's ready within a few hours of it being sent in. Didn't receive a text. I waited until Friday the next day, and still no text in the morning. And it was a little confusing to me because I knew that this could be filled pretty quickly. When I spoke with the tech, they said, hold on one second, I need to refer you to the pharmacist. And the pharmacist got on the line, and they told me, I do not feel comfortable filling this particular prescription at this dosage because of the Idaho laws, and that you need to call your physician and have them send this prescription somewhere else. I tried to stay calm, and I just responded to the pharmacist, and I was like, this is being prescribed to me because I'm having a miscarriage. I have a non-viable pregnancy. I'm at 7 weeks, and my understanding is that this is a legal reason why this medication is prescribed. And they repeated back to me the same thing, that they did not feel comfortable filling this prescription because of the laws, and that I needed to consult with my physician to get it sent somewhere else.
Obviously, there was some frustration there on a lot of levels. One, being kind of involved with trying to figure out how to navigate this law, and then frustration from kind of like a professional responsibility level. It was coming from a place, probably for this pharmacist, of fear, not judgment. And so trying to recognize that there are probably a lot of people in that position, and trying not to place the blame on the pharmacist, but on kind of the environment that's been created because of our laws, and how can we do a better job of making sure that this doesn't happen to someone in the future.
The way that I process grief personally is I'm a planner. And so that was why I had chosen to go with the medication. It allows you to, predict a little bit more when you're going to actively miscarry, and you can go back to your normal job. It's hard as a woman to, if you were actively miscarrying, to be at your place of work. So, I was frustrated with, dealing with my own grief already from this 5th miscarriage, but also like it kind of gave me perspective of, wow, I live in a place like Boise. I have access to other pharmacies. What about other women across the state who wouldn't maybe have access to another pharmacy? And if their pharmacist chose to not fill this prescription, what would they be able to do? What options would they have? I think infertility, at least what we've experienced, is it's a club nobody wants to be a part of. But sadly, there are a lot of women that have trouble getting pregnant and that have recurrent pregnancy loss. And, throughout this time, our journey, we've had a lot of people tell us about pregnancies that they've lost that they never talked about. The experience that we've had has created a sense of community amongst our friends and our family, and we personally are more open about it. But I think across the state, with the laws and the access issues, I really hope that women feel empowered to be able to understand what the laws allow them to do and can make those decisions for themselves.
It definitely gives you a sense of empathy and compassion for what your patients are going through, right? Miscarriage is kind of just part of the normal experience. It's not that rare. It's quite common. Knowing your options and knowing that you can access those options without difficulty can make that experience something that's either painful but manageable, or incredibly painful. Trying to minimize those barriers for people, I think for me now, is paramount whenever I provide miscarriage management. When we talk about options for miscarriage, there's kind of 3 that we generally talk about, and that is expectant management, basically kind of waiting for your body to miscarry on its own. There's medical management with medication, which is mifepristone and misoprostol, are the medications that are generally used. There's other ones as well to kind of expedite that process. And then there's procedural or surgical options. It's just really important to have all 3 of those options available. As you said when you start out, like these are not like, they can be life-threatening, but these aren't necessarily life-threatening situations. These are just, again, a common part of reproductive care when you're trying to get pregnant, is that you're probably going to have, most people are going to have a miscarriage at some point in their reproductive journey. And it's just important to have all of these things available for your health care whenever that happens to you. In family medicine, especially in family doctors that choose DOB, we're trained and we have the medical knowledge of how to provide it. But a lot of people, when it comes to that moment, again, when all of a sudden you kind of have this law flash in the back of your head and you're thinking, that's prison time if I do this wrong, I think people stumble, right? And people get nervous, and they either don't provide the correct care or they provide misinformation because they're nervous. And so I think a big part of what we did was kind of scripting it out and making sure that everyone knew the guidelines to follow and what our policy was at our organization, and that it was very clear that miscarriage management in particular is 100% safe and 100% legal. Miscarriage management and abortion are practically indistinguishable from a medical standpoint. And so even though I am providing this care in the context of miscarriage management in my clinic, they're the same skills that someone would use to provide an abortion. And so I think that there's always that fear of that getting misconstrued, of someone kind of, hearing about this, even in kind of trying to speak up about it. I think it creates a real fear, and I think that we always have to talk about, unfortunately, having a contingency plan, that if for some reason, from a legal landscape, things kind of get too hot here and it feels like I can't provide medicine like I feel like I am ethically obligated to do, that at the very least I have to give up OB. But then worst case scenario that I can't practice here anymore.
I love the work that he does. I will say that I know that it keeps him up at night. He works really hard at, all of the things that he talked about, making sure that there's education available to his residents, and that he's the go-to person. They call him, they consult him. He also works in many other advocacy groups and speaks with legislators. When we moved here, it wasn't like this. He really felt like he could do his job to his full capacity in the way that he wanted to do it, and that has shifted. And if it gets to a point where he feels like he can no longer do that here in Idaho, we will consider moving, probably, which is hard. We've built a community here, we love it here, and we want to stay.
When Dobbs happened and our trigger laws went into effect, I think a lot of family doctors, myself included, were nervous about being able to still provide OB care. I think that Idaho in particular is unique in that we rely heavily on family doctors to provide OB care throughout the state, particularly in rural areas, because we just don't have enough OBs. I had feelings of confusion, and that there were probably a lot of other folks out there that felt the same way. I got plugged into these different groups that was basically doctors much smarter than me trying to figure out, again, just create protocols, like what do we do? What do we do in this situation? What do we do in that situation? And so that people felt like they had some sort of process to follow, because I think people's immediate reaction was, I just can't provide OB anymore, which was I think very sad, especially for us family docs that kind of pride ourselves in being able to provide OB as well, and we're feeling like they weren't getting any guidance from anyone. We went. I remember with my professional organization, the Idaho Academy of Family Physicians. We went to the governor's office to talk to them about this, and we went to legislators to talk about this. Of what are we supposed to do now? And the answer we got was, well, you all have to figure out what to do. We just made the law. Now you have to figure out how to practice under it, essentially. And I think that was really disheartening. I think the medical community was waiting for some sort of guidance. You completely changed the landscape of how we provide pregnancy care here in the state. So now tell us how to do that. And we're essentially told that's not our jobs. Our job was just to make the law, and you all can kind of figure out how to practice around that. We started raising a lot about the confusion with how the law is written, particularly around its exception to provide abortion care to prevent the death of the pregnant woman. And it was also, I think, really disheartening when we were trying to express our confusion that we were essentially getting mocked by our attorney general of that the law is crystal clear and why can't you figure it out? And then it became incredibly partisan too, of you're getting bad information from bad actors who are trying to use you as a political tool, instead of just recognizing the challenge of the situation and trying to work with us. If this is what they want, is for us to figure it out, then we'll figure it out. But we're not going to say that it's the standard of care or that things are great now, and that now that we've got this all figured out, now OB is so much safer, because it's not. They've very much interjected themselves into how we practice medicine, but then say, but we're not doctors, but we don't really, it's not our job to figure this out, because we're not healthcare providers, and it just emphasizes not just, with the abortion bans, but with any time you legislate medical care, that, you should probably be ready for what your contingency plan is going to be, for how that's going to change the medical landscape, or at least even talk to medical providers about it before you make that law. I don't think that there was any legitimate effort to do so. I think that those laws in particular, because they were passed before Dobbs, were passed to basically score political points with a lot of our politicians' bases that identify as pro-life, without even thinking about the potential consequences to just providing pregnancy care. And that's not me just kind of theorizing that. That's me talking again to legislators who said exactly that of, well, when I voted for this, I didn't actually think about what would happen if it went into effect, which just blows my mind that you would pass a law without even thinking about what the actual consequences of it would be.
I think it's just, I think education is so important, and understanding what the laws are and understanding that you have options, and just, you know, all of the work that the clinicians are doing is to help us be safer and get the care that we need. They're fighting for us. I think a lot of people are, you know, confused and frustrated, and my advice would be, you know, just educate yourself as much as you can at this point. I mean, this is the situation we're in, sadly, and hopefully we can make some changes, but just having a level set of knowing what you can and can't do, I think, is really important.